So let's start. So cirrhosis is a very important topic, not only from USMLE step 1 standpoint, but also from clinical standpoint too, because you will see these kind of patients in the hospital a lot too. So for step 1, step 2 CK, and step 3, and then later in residency training, cirrhosis is a very, very important topic. So what is cirrhosis? It's a fibrosis of the liver. It's a fibrosis of the liver. That's the simplest definition. Scarring of the liver. So if you look at the microscopic changes, so we have hepatic lobule, we have central vein, and you will see fibrosis around the central vein, or the architecture, our liver architecture will be disrupted. So you will see fibrous bands. You will also see some fatty changes in the liver along with fibrosis, because there is a lot of fibrosis around the vein. This will compress this central vein, which will result in portal hypertension. Blood will not flow properly. So this is all fibrosis, these fibrous bands. What are the causes of cirrhosis? The most common cause in the United States is alcoholic liver disease. And then after that, Hep B, hepatitis C. And then we think about autoimmune causes, primary biliary cirrhosis, autoimmune hepatitis. We think about metabolic causes, Wilson disease, hemochromatosis, alpha-1 antitrypsin deficiency, glucosemia. But the most common cause, alcoholic liver disease, hepatitis B, and hepatitis C. So whenever we have a patient with cirrhosis, number one question we always ask is drinking. Number two, second question, we order hepatitis panel. And third thing we always do is we check the drug level too. We check Tylenol level, because if someone is taking Tylenol and drinking at the same time, they have high risk of liver failure. So next is, what are the complications associated with liver cirrhosis? We will be discussing these complications one by one. So hepatic liver failure can happen, hepatic encephalopathy can happen, portal hypertension, ascites, hepatorenal syndrome, hyperestrogenism in male, estrogen level will go up. Hepatic failure. Basically, end stage liver disease is hepatic failure. How can you diagnose hepatic failure or liver failure? You have to check coagulation panel. If the INR is high, especially greater than 1.5 in the question, think about hepatic liver failure. And then we were discussing about liver function test, which will indicate the functional capacity of the liver. So how to assess those tests? So number one is coagulation panel, check INR. Number two, so you can also check PT. PT will be high. Look at the albumin level. If the albumin level is low, that indicates liver failure. Next, check the bilirubin level. So this is how you can check the functional capacity of the liver. One other clue in the exam question or in the real life situation is you can look at their platelets level too. And these patients are patients with end stage liver disease. They have thrombocytopenia. Because their albumin level is low, that will result in decrease on cardiac pressure, and that can cause pitting edema. They can have anasarca, edema of the whole body. Next is hepatic encephalopathy. It's basically change in mental status, altered mental status because of increased ammonia level. So we know that liver is damaged. The function of the liver is to convert ammonia into urea. If liver is not functioning properly, ammonia level will go high, and this ammonia level will cause altered mental status. When you examine these patients on physical exam, these patients have asterexis. They have flapping tremors. It's a tremor with outstretched hand. So when you tell these patients to outstretch their hand, to lift them forward and outstretch them, their hands will be flapping up and down. So that's why they are called flapping tremor, asterexis. So they will be altered, orientation will not be right. Sometimes they can have balance issues. Sometimes they can mimic symptoms of stroke, but the symptoms will be non-focal. What are the precipitating factor of hepatic encephalopathy? How it happened? Why it happened? So there are so many risk factors. So what are the precipitating factors? So there are things which can increase ammonia level in the body. So liver is already not functioning. Liver is not converting ammonia into urea. So ammonia level is already high. On the top of this abnormality, there are certain other things which can increase ammonia level. Increased protein intake. So protein, we all know, is converted into ammonia and then converted into urea. If liver is not there, if you consume more protein, more ammonia level. GI bleed, we know that blood is also a protein. If someone is having GI bleed, they will produce more ammonia. Infection, commonly urinary tract infection, UTI, pneumonia, skin infections, also increase ammonia level. Constipation, increase ammonia level. Alkalosis can increase ammonia level too. So first, there is increased production of ammonia. Second, decreased removal of ammonia. So first, liver is not functioning. Second, renal failure. We already, and we will discuss this in detail in the kidney, that how ammonia is handled by the kidney. But we know that in proximal convoluted tubule has a mechanism of getting rid of ammonia. If there is a kidney failure, then ammonia level will go up. Diuretics. Diuretics can increase ammonia level too by dehydration. Diuretic can cause dehydration. Bypassing hepatic blood flow, this is basically the mechanism. So basically, TIPS procedure. So transjugular intrahepatic portosystemic shunt. So basically, you are bypassing the liver, going into internal jugular vein. So liver is not functioning. So let's say whatever ammonia is produced in the portal system will go straight to the brain and can cause hepatic encephalopathy. Treatment, we usually start with correct the precipitating cause. That's number one. Second, give them lactulose. Third, we can use rifaximin. Neomycin is not available in the United States, but it is used outside US. So we can use lactulose, we can use rifaximin. Next is portal hypertension. Because liver is damaged, liver is fibrosed, and we have a portal blood going towards the liver, so there is a lot of fibrosis, and because of the fibrosis, the liver is compressing all the vein inside the liver, and the blood is not moving forward. So this blood will start backing up in the abdomen. So that will result in different complications. So let's say if blood is not moving forward, usually the venous blood. So blood will start accumulating. Number one, it will cause ascites. Because the portal vein is connected to splenic vein, so the pressure will move towards spleen 2. It will cause splenomegaly. Third, the pressure will be transmitted to left gastric vein, to the lower part of the esophagus, which has esophageal vein. Those veins will be dilated. That will result in varices. 4, it will be transmitted to inferior rectal vein through inferior mesenteric vein. That will result in hemorrhoid. And then they will be transmitted to abdominal vein, epigastric vein, which will result in caput medusae. So wherever there is portosystemic shunt, there will be complication. So these are the complications of portal hypertension. So shunt used in treating portal hypertension, you don't have to know this. The only thing if you can remember is TIPS procedure, transjugular intrahepatic portosystemic shunt. So in this procedure, basically you have liver is damaged, the blood is not moving forward, so you will place a shunt between portal vein. The shunt will go through portal vein all the way into the inferior vena cava and then into internal jugular vein. So basically you are bypassing the liver. So this is called TIPS procedure. Try to avoid it as much as possible in the hospital because it has a lot of complication too. And it also increases the risk of hepatic encephalopathy because you are completely bypassing the liver. So whatever the ammonia is produced in the portal system, that will go to internal jugular vein eventually, and from there it can go to the brain and can cause hepatic encephalopathy. But in case of life-saving situation, the tertiary care hospital, they do this procedure. Next is ascites. It's a complication of cirrhosis caused by portal hypertension. This is exacerbated. So let's say liver is damaged, the blood is fluid is accumulating in the belly, but there will be more fluid accumulation because patient albumin is already low, liver is not producing albumin too. So there will be decrease on oncotic pressure, which can actually exacerbate ascites. And then there will be third spacing too. What is third spacing? So intravascular volume depletion. Because of decrease on oncotic pressure, decrease albumin, that will result in decrease on oncotic pressure. So fluid will be leaving the blood vessel, and the kidney will start thinking that there's not enough pressure in the body. Blood pressure is low, and kidney will start producing aldosterone. So kidney will sense that blood pressure is low because of intravascular volume depletion, because of decrease on oncotic pressure. So kidney will produce increased aldosterone, aldosterone will result in increased reabsorption of water along with sodium. So you are reabsorbing along with what you are accumulating in the belly. So that will actually exacerbate ascites too. So rule of thumb is whenever you have a patient with ascites, the first test you have to do is ascitic tab. That's the rule of thumb. You'll do it in the ER. If not done, do it on the floor. Because you need to do peritoneal fluid analysis. You need to see what is going on in there. Once you have the result of this test, you need to assess what is the cause of this ascites. Is it truly from the liver, or if there is something else going on resulting in ascites? So for that, you need to calculate SAG. I would not say grade ratio. I would not say ratio here. This is not a ratio. This is gradient. You should correct that. This is a SAG gradient. So serum ascites albumin gradient. So you will look at the serum albumin and then subtract it from ascites fluid albumin, and if the level is greater than 1.1, that's the magic number. If it is greater than 1.1, then you will think about portal hypertension. But if it is less than 1.1, then you have to think about other causes of ascites. Let me give you a quick flow chart by which you can quickly determine the cause of ascites, especially in the exam. So let's say they will give you ascitic fluid analysis in the question, and you calculated SAG gradient. Now it will be either greater than 1.1, less than 1.1. So if it is greater than 1.1, okay, one thing, if it is greater than 1.1, it does not mean that patient has cirrhosis. It means patient has portal hypertension. You need to assess more. What is the cause of this portal hypertension? Now, commonly, portal hypertension at your level, when you are preparing for the exam, they will commonly confuse you between two diseases. So between CHF and liver cirrhosis. Because both liver cirrhosis and bad CHF can cause portal hypertension. CHF can cause back pressure, heart is not pumping, pressure will be transmitted to the liver, eventually to the, it can cause ascites too, if it is bad. And liver cirrhosis, we already discussed, it can cause portal hypertension. But how will you differentiate between these two conditions when you already calculated that SAG is greater than 1 and you have to assess what is the cause? So in case of liver cirrhosis, albumin will be less than 2.5. In case of CHF, albumin will be normal because liver is actually functioning in CHF. So that's the main thing by which you can differentiate by looking at the albumin level. You can also look at the coagulation panel. Look at the INR. So it will be abnormal. That can be used as a clue. In case of CHF, coagulation panel will be normal. Now let's say if the SAG is less than 1.1 and patient has ascites. Now what is the cause of ascites? In this kind of situation, the most common thing you should think about is kidney. Look at the UA, urine analysis, and you will see proteinuria. So patient is actually losing protein in the urine, which is decreasing oncotic pressure, resulting in ascites. So kidney is the most common cause you will see. So this is how you can quickly differentiate and find out the cause of ascites based on SAG. So when you are looking at ascitic fluid, you need to assess, is it a transudative fluid or exudative fluid? So transudative fluid is basically caused by increased portal hypertension. And exudative has so many different causes, tons of causes. So here, because we are discussing about cirrhosis, so they mention causes liver disease, but transudative can be caused by CHF, liver cirrhosis, Budd-Chiari syndrome, anything which increase intra portal pressure can cause transudative effusion. Budd-Chiari syndrome, hepatic vein thrombosis, and then exudative, so many other causes, infection, rheumatoid arthritis, peritonitis, cancer, TB, many causes. So in case of transudative fluid, the SAG gradient will be greater than 1.1. If it is a liver disease, the protein level will be low. So you can look at the protein concentration less than 2.5. WBC will be less than 300. Neutrophil will be less than 25%. So neutrophil is more important. Just remember neutrophil. If it is exudative fluid, they mention common cause peritonitis, spontaneous bacterial peritonitis, which is common in patient with ascites, which is one of the reason that any patient present with ascites, you have to do ascitic tab, because you have to rule out infection. If they have fluid in the belly, you have to think it is infectious. So rule out infection. So SAG will be less than 1.1, but it can be greater than 1.2. Let's say if the patient has liver cirrhosis and they have now ascites, and that ascitic fluid is infected, so SAG will be greater than 1. So this is not the rule. So here the peritonitis they mention is not spontaneous bacterial peritonitis. They mention peritonitis from infection. So what is mean by peritonitis here? In what kind of peritonitis SAG will be less than 1.1? So let's say if they have visceral rupture, they have kidney abscess, they have liver abscess, they have peptic ulcer disease, and peptic ulcer is now rupture. That will result in ascites, and that can cause peritonitis too. So in those kind of cases, the SAG will be less than 1.1 because liver will be normal in that case. In infection, because of these cases, protein will be very high. Protein in the ascitic fluid will also be high. So they are assuming liver is normal. And then neutrophil obviously greater than 25%, indicate infection. Why this is important to differentiate? Because let's say if the patient has visceral rupture and you are thinking, so let's say if the patient has now case 1, so this is case 1, this is case 2. So this patient has liver cirrhosis and ascites, and this patient has no liver cirrhosis, but this patient has visceral rupture causing ascites. So in visceral rupture, let's say if you treat this patient as liver cirrhosis ascites, this patient will die and mortality is 100%. So what these patients actually need is laparotomy, surgical intervention. In these patients, let's say if this patient has liver cirrhosis case 1 and they have ascites, and you start thinking that maybe this is a visceral rupture. So in these patients, actually, if you do surgery, let's say if you take this patient for laparotomy, mortality is 80%. You cannot do surgical intervention on patient with ascites secondary to liver cirrhosis because mortality is very high. So that's why it's important to differentiate between these two cases. Hepatorenal syndrome. So in patient with cirrhosis, increased portal hypertension, that will result in increased level of vasoactive amines in the abdomen, and they will increase vasoconstriction in the kidney, which is one of the complications of liver cirrhosis. So that's why it is called hepatoliver affecting the kidney, hepatorenal syndrome. So these patients can have renal failure. It is reversible initial stages, but later stages it is irreversible. So creatinine clearance, you don't have to remember this creatinine clearance. So they will have liver failure and kidney failure. Their creatinine will continue to go high. They will not respond to anything. You give them fluid, you give them albumin, you give them Lasix, nothing will help. So their UA will be normal. That's one clue. Because these patients have hepatorenal syndrome, so the first thing you will check is the renal. You'll check their urine. Their urine will be normal. No proteinuria. Random urine sodium will be less than 20. But BU and creatinine continue to go high. So it means that there is renal vasoconstriction going on. And by the way, the exact mechanism of hepatorenal syndrome is unclear. So they are thinking that's because of vasoactive amines produced because of liver cirrhosis, which is causing renal vasoconstriction, and that is also renal failure. So this is very, very simple hyperestrogenism in male. So basically, liver is responsible for the metabolism of estrogen in male. So liver is responsible for metabolism. If liver is not functioning, the estrogen level will go up. And when estrogen level is high, these patients can have clinical finding like gynecomastia, hydrotelangiectasia. So basically the capillary, the small vessels, they will be dilated. And that's why you can see dilated vessel in the hand or in the arm or on the belly. Female distribution of hair can happen. These patients can have impotence or erectile dysfunction. The simple mechanism is liver is not functioning. Liver is responsible for estrogen metabolism. If liver is not there, then the level will go high, and then you will have symptoms of high estrogen level.